Hello and welcome back to Communicable, the podcast brought to you by CMI Communications, Escomet's open access journal covering infectious diseases and clinical microbiology. My name is Angela Huttner. I'm an infectious disease doctor at the Geneva University Hospital in Switzerland and editor-in-chief of CMI Comms. I'm joined by my co-host, Josh Nosanchuk, fellow editor at CMI Comms, an infectious disease clinician and professor of ID and medical microbiology at Albert Einstein College of Medicine in New York, where until recently he was also dean of education.
Thank you, Angela. We're excited to welcome two guests today to discuss the World Health Organization's Fungal Priority Pathogen List. The first is an early friend of the podcast, Dr. Hatim Sati. Hatim is a medical doctor who hails from Sudan. He is the project lead of both the Bacterial Priority Pathogen List and the Fungal Priority Pathogens List, and a technical officer in the WHO's Antimicrobial Resistance Division. Hatim, welcome back to Communicable.
Thank you. Thank you for having me. Pleasure to be back with you, Josh, and good to see you again, Andrew.
Thank you. Our second guest is Professor Dimitrios Kontoyiannis. Dimitrios is also an infectious disease clinician and the Robert Hickey Chair in Clinical Care and Deputy Head of Research in the Division of Internal Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. His group studies various aspects of fungal biology, fungal diagnostics, and antifungal discovery and immunotherapy. He is currently the president of the Mycosis Study Group, Education and Research Consortium. Welcome, Dimitrios.
Thank you very much, Angela and Josh. Hi, Hatim. I'm honored and happy to be here.
So as our listeners know, we always start with a get-to-know-you question. What is the strangest or most memorable plane or train or boat ride you have ever had? Josh, you first.
So I'll go with a canoe trip. In college, a friend of mine and I would go up into the Adirondacks and pick a different chain of lakes. In one case, it was the Fulton chain. And so we had about 4 or 5 days where we had our backpacks and our canoe and just went out in the wild and took our time. And it was incredible. It was very peaceful. How about you, Angela?
Oh, I love that. I have a thing for night trains. When I was 14 years old, I was traveling from Trieste in northern Italy to Rome, which I had not yet seen, with my big sister, Julie. So Julie is 10 years older than me, and I worshipped her, as little sisters often do. So I was really happy to share this train ride into the unknown with her. And it was twilight when we left Trieste. The train tracks go around the whole Gulf of the Adriatic. So watching the sea change colors and the stars come out as this train made this clattering noises along the tracks, it was just really magical. And I still remember the smell of the salt air, the chill as it got dark. We had the windows open and just the excitement of this unknown thing ahead of me, but the pure comfort of having my sister go with me. I think that was my seminal night train experience, and that is why I love night trains.
That's terrific.
Hatim.
Well, mine was more along the funny lines. I was in a mission in St. Kitts and Nevis in 2018, I think, with another colleague of mine. And we arrived for the connection, and the plane was very small. We were told that they have to weigh each of us before we get on board to determine where people should be seated.
What?
Yes, we were asked to go on the scale. The flight attendants for extra measures looked you up and down, and they're like, you sit there, you sit here. It was kind of nerve-wracking, but also funny at the same time. Yeah.
I hope everyone was sort of like of a standard body habitus, shall we say? Like,
become self-aware suddenly, right? When you're told, in a way, everyone's life dependent on it in the moment. Yeah,
I'll bet you don't forget that.
Actually, there's an airline, Cape Air, that flies, for example, from Boston to Cape Cod, and they do the same thing. New York to Hanover, New Hampshire. And they weigh you, they weigh your luggage, and they distribute you. So it happens in the States too.
Wow. Okay. Good to know. And finally, Dimitrios.
That was a good question. It made me go back. And I have this memorable, anxiety-provoking, nerve-wracking boat ride. It was almost 40 years ago. I was in my mid-20s. I was in the military. Before I came to U.S., we have compulsory military service in Greece. And I was supposed to go as the military doctor along with 30 other soldiers to replace a garrison in the middle of the nowhere in the Aegean Sea. We went there. There were 30 soldiers with all their gear and cargo to replace supplies. on a small boat and we found high seas. And in the middle of the high seas, I realized at least 10 people did not know how to swim. And they became very panicked, started grabbing my leg, arms. He said, I don't want to drown. And the boat was at the risk of capsizing. I did some hard prayers. I'm not a praying person, but I did some very, very, very hard prayers. Said, if we're going to capsize, I'm going to drown. I cannot swim with 3 other people holding me. But thank God, Poseidon or whatever, the boat made it, and here we are.
Wow, that is also clearly unforgettable. My goodness.
Well, we'll take your prayers anytime, Dimitrios. So one of our very first Communicable episodes was on the WHO's then newly updated bacterial priority pathogen list. But we knew we also needed to talk about WHO's fungal priority pathogen list. We had a recent episode with Dr. Arturo Castoval that discussed our warming world and how that's making fungi ever more relevant and more unavoidable, especially as pathogens. So we're delighted to have Hatim, who is the project lead on the list, to give us the inside story, and Dimitrios to give us his independent expert commentary. So, Hatim, can you give us the context? How did the WHO Fungal Priority Pathogen List come to be, and what are the key components of that list?
As you all know, fungal diseases are causing far more harm than most people realize. Millions of people impacted globally in terms of not only mortality, but also morbidity. On top of that, the rise of antifungal resistance was of major concern, and it was in the radar of the WHO for a while now. But what's surprising, despite that burden, fungal diseases have largely been missing from the global health conversation. Overall, the area is under-recognized, underfunded, and almost invisible in terms of the policy discussions, particularly around MR, where we are focused. The WHO developed in 2017 the first bacterial priority pathogens list. That list has been really instrumental in drawing attention and shaping and guiding the conversation, and also the investments towards unmet needs in terms of research and development of new medicines and tools. In 2022, we set out to do something similar for fungal pathogens. I was tasked at the time by my colleague Peter Baer, who is now in GART B, he was unit head at the time, to explore the possibility and the value. I had the privilege to start the conversation with a group of stakeholders, and we engaged a wide group representing all the different sectors, different disciplines, clinicians, scientists. We tried to assess gaps and understand how a prioritization exercise could support more coordinated action. Early on in the conversation, it became very clear that this is different in terms of scope and scale than with the bacterial priority pathogens list, because quickly you realize this is not only about resistance, that the mycology field at large is chronically under-resourced, treatment options are limited, often associated with toxic side effects. Diagnostics are largely also variable in terms of their sensitivity and availability and accessibility also in different settings. And so we established a formal WHO advisory group through an open call. We received a fantastic number of applications, and after the initial assessment, we embarked on the list. 45 senior experts were involved, but also a broad group of experts from across the world helped us in prioritizing these pathogens. Of course, the guiding principles were burden of disease, the public health impact, and the implications across the One Health spectrum. The selection also reflected this broader environmental, ecological drivers that impact or come to play when it comes to fungal diseases and to fungal resistance. And so finally, these were ranked and grouped into 3 tiers of priorities, as we always do, critical, high, and medium, and was published in 2022 with a report and number of recommendations at the time to draw the attention to this increasingly important area.
When you talk about the stakeholders, you mentioned a couple in passing, but to really drive it home, who are we trying to get these components to?
Top of the list was decision makers, of course, also We were targeting drug developers, diagnostic developers, people who are interested in investing in R&D, pharmaceutical sector, and the general public as well, because awareness is key. The evidence through the consensus of these experts from different disciplines, clinicians, microbiologists, even basic biologists, to establish a prioritized framework through which we could anchor the conversation with decision makers around the impact, the burden, and the cost of action, but also, more importantly, the cost of inaction.
If I may interrupt there, Hatim, I do notice that on your list of your audience, let's say, those drug developers are quite low on the list. I think in contrast with the bacterial pathogens list, if I remember correctly. Does this therefore reflect a willingness on the part of WHO to say, look, first things we need to do here are decrease transmission, clean up a little bit before moving to actual drug development?
I think you're right in that order was not random. Our first goal was to bring this to the attention of policymakers, first and foremost. In this case, our strategy was first and foremost to draw the attention to this area across the board. Fungal diseases, some of which are quite complex, some are resistant, some are not, some are simply difficult to treat. And so we wanted first to raise the awareness around the importance and around the gaps in terms of funding, etc. One of our goals, of course, was also to encourage investments in this area, knowing that perhaps from a pure market point of view, this area has been unattractive to investors, the infectious diseases at large, but particularly mycology, and that there is not only a value in these investments, but also there is a true societal need for such innovation and such investments in new treatments and diagnostics.
So one of the things that I think is so important is that it is a global list, but at the same time, there are areas like you were mentioning that may have issues that are significantly higher. So sporotrichosis, for example, in Brazil, and sporothrix is not one of the organisms on the list. So one of the conversations I've heard is, should there be more of these lists? Should you have the global one, but then should you split down and say, okay, but for this region, and again, for political purposes in terms of public health and information and heightening the understanding of that impact, should you also have some regional, perhaps, priority pathogens?
Absolutely. In fact, these are some of the lessons learned from the first list. Of course, we stress in the report that this list is meant as a global list and must be contextualized to the local context, the regional context. But we definitely understand that leaving some pathogens out of the list have implications also in terms of funding and in terms of the impact for the populations affected by these pathogens. We are now embarking on 2 projects or tracks to sort of remedy this gap. The first is we are going through a series of exercises with some countries and with some regions to contextualize the list and develop regional list. And one of these is the Latin America and the Caribbean region. Currently, we are working with a group of experts from Latin America and the Caribbean to develop their own fungal priority pathogens list with the aim of starting with a manageable and a feasible list of pathogens to be addressed. The second is our report was recommended by the steering group that the list must be revisited every 5 years. So towards the end of 2025, we have planned already the start of the review of the fungal priority pathogens list. And in this time around, we will address some of these lessons learned and keep in mind some of these unintended consequences that we saw in the first list.
So, Hatim, why was the One Health approach so important for this list?
The thing about fungal pathogens is that the epidemiology of fungal disease is shaped by complex interactions between human, animals, and most importantly, the agriculture sector. In fact, one of the major drivers of antifungal resistance, as you know, is the massive use of fungicides in the agricultural sector. Scientists like Arturo and Dimitrios are telling us that the emergence is driven by factors like climate change, deforestation, urban expansion, antifungal use in plants. And so these forces are reshaping the ecology in ways that directly affect human health. At the same time, health systems, especially in limited resource settings, are not often equipped to deal with such a threat that requires high level of funding and high level of coordination across sectors. And so in these cases, One Health approach here is not just a concept. It's a needed practical framework really to address these types of threats. Also, it's a must to not only inform the priority setting, but also inform the interventions and the action. This kind of systems level of thinking is really, really needed in medical mycology.
In the next reiteration, would that be interesting in the future to link or tag the burden of aspergillosis with the burden of tuberculosis and target post-tuberculous capillary disease? That's one example. The second, in the context of the bacterial resistance and very complex interactions between bacteria and fungi. For example, you go to cystic fibrosis. When we see a lot of bacterial infections, common disease, a lot of antibacterial, multidrug-resistant bacteria, and then aspergillus or Scedosporium. Can we go to more geographic or sequential bacterial, fungal, or host-specific priority list to make it more nuanced? The second iteration of this.
These are all fantastic ideas, and they reflect the complexity of fungal diseases and antifungal resistance. I think one suggestion was also looking at this from global versus endemic lens. Like you suggested also was, looking at this in terms of association. And I think during COVID-19, this idea of a superimposed endemic on top of an endemic COVID-19 fungal-associated infections. In the context of cancer treatment, such as the work you lead, there is the question of the underlying population at risk in terms of the social determinants of health. And this is something I've been thinking about. You and I had collaborated on one paper to try to pose these questions. What does it mean to have more conflicts in the world? The impact of climate change, the mass migration, and the impact in terms of certain occupations. And so there are a number of ways you could dice or slice this. Of course, our hope is through the next iteration is to have, again, a strong multidisciplinary group of scientists who could help us in perhaps framing this in a way that makes sense.
Yeah, I could see the Transplant Society having their own priority pathogen list. It would be very interesting. The Fungal Priority Pathogen List is under 3 years old. It's still really young. But Hatim, could you share any examples of a direct impact of this?
I think one of the most important impacts was shifting the conversation. Really, before the Fungal Priority Pathogens List, in my opinion, communicating about fungal disease often felt like an upstream battle. But with the Fungal Priority Pathogens List, we finally have a structured, evidence-based tool to anchor this conversation around. And also it gave us a way to talk about fungal diseases, not as an isolated clinical problem, but rather as a global health issue. And really the shift was not unnoticed. I don't know if you're familiar with the piece that was written by Denning and Fisher in Nature. They described this as a game changer. And this has been the feedback we're receiving from a lot of scientists, a lot of clinicians and researchers, that the list truly moved the needle in terms of funding. Nowhere near what we are aspiring, of course, to arrive to, but at least now this is part of the conversation. For example, we see in the UK number of government and non-government funders have issued calls for proposals for researchers with research focusing range on R&D, basic research, etc. Similarly, now in Denmark, there's a big push to fund research related to fungal infections and narcotic diseases. In terms of awareness, our communications department actually picked an uptick of the uptake using certain terms in social media and the media. And it's estimated that since 2022, the list has been covered in over 150 news articles across 8 languages. And this is really a true impact in terms of bringing the conversation also to the public. Because if you bring the conversation to the public, public awareness really often leads to pressure on decision makers and policymakers in action. And that's what we're hoping really to have.
An opportunity also to reach out to philanthropy efforts and advocacy through non-government entities. For example, there have been a very telling CDC survey in infectious disease practitioners outside academic centers and asked the question, hey, have you ever heard post-influenza aspergillosis? And 35% of them never heard of it as an entity. So I think also opportunities here is to educate the public, and a good catalyst may have been the COVID and mucormycosis explosion in India, when for the first time in my life, a fungal disease made it to New York Times and to the main press. And also emphasize this is a pathogen also in the WHO list. Just, educate the public and the people who can give money towards fungal disease.
Yeah, I think it's fantastic. When WHO lifts its microphone, really the world is listening. Still, even with what's happening today, it's hugely important. Can we just go back for our listeners, Hatim, and can you just tell us what are let's just say the top fungi, the way it's ordered, it's just like the bacterial pathogens list, and how are they selected?
Well, as I mentioned, the preliminary list of fungi to be ranked were selected through a consensus process through the advisory group that was established for this purpose. Each of these 19 pathogens were then assessed against a set of 10 criteria covering the burden of disease, both fatal and non-fatal burden, antimicrobial resistance impact, transmissibility, the trends of infections, the distribution, treatability, and status of the pipeline. This followed, of course, a multiple criteria decision analysis approach that allowed us to fill in gaps in evidence with the experts' consensus. And then to determine the weights of each of these criteria, we conducted a global discrete choice experiment survey with the participation of over 375 experts from across the world. The survey actually was translated to 3 languages to ensure full participation. And then accordingly, the list was scored. And then a group of 55 senior experts who constitutes the core group determined the public health weight of each of these pathogens versus the R&D needs through a best-worst scaling approach. And so accordingly, we have 19 pathogens in the critical list: Cryptococcus informans, Candida auris, Aspergillus fumigatus, and Candida albicans. The high group contains a mix of pathogens that are endemically globally distributed, including Candida glabrata, Histoplasma species, Eumycetoma, Mucoralis, Fusarium, Candida tropicalis, and Candida propylosis. In the last category, we have pathogens, some of which are very rare, some of which are endemic, like coccidioidomycosis, paracocci, as well as teluromyces. Some of these pathogens are very relevant to certain populations, like people living with HIV in certain areas, Southeast Asia, or in Latin America and the Caribbean. And then the list, of course, came with this caveat that it is a global list, that the list is diverse pathogens in terms of their distribution, their impact, and that it is extremely important to stress the need for contextualization, but also to stress that this list is not exhaustive. Now, if you examine the pathogens in some of these categories, perhaps for some regions, some of these rankings will shift in terms of the priorities, but we thought that this is an okay balance. In the critical list are globally distributed, and we tried to strike that balance, I think, to the extent we could. For example, Candida auris, for the emergence of these pathogens and the impact of these pathogens globally, and the impact of climate change and how these pathogens are also emerging, not in isolation of environmental drivers. First isolated in 2009 in Japan. Fast forward, it is reported in over 55 countries, with some devastating outbreaks in many countries.
Dimitrios, do you agree with the pathogens that made it to the critical versus high priority?
Yeah, I tend to agree with all these caveats. I think the other thing to emphasize, this list also try to capture burden of disease. And fungal infections are not bacterial infections, they are subacute or chronic infections. So if you see there, with the exception of some kind of acute illnesses like Candidiasis that tends to behave like bacterial infections, a lot of the fungi that made to the list are chronic disease like coccidioidomycosis, mucormycosis, aspergillosis. So if you look for the public perspective, burden of disease, patients, 1,000 days, and resources, that's another way I think this list is relevant. Not only the morbidity and mortality, but also the resources needing to study them, diagnosing them, and treating them. So if I wear my public health hat that I don't have, that I think is a very appropriate first step.
Yeah, I would also highlight the eumycetoma. That's something that in developed countries, high resource countries, you don't see a lot of that. But it doesn't take much if you travel to some other places. And even within a space like Brazil, they have very different distributions of mycetoma. The causative agents are different in different spaces. The diagnostics are terrible and the treatments are terrible. So having this complex distribution is really rich, I think.
Yeah, and Josh, just to add, the example of mycetoma, and also the outcome is devastating. I come from Sudan, and Dr. Ahmed Fahal was one of the pioneers in this area, the Mycetoma Center of Sudan. Sudan is not a very rich country, as you know. It's a low-income country, and yet that center used to receive patients from all over the Horn of Africa. And unfortunately, since the conflict started in Sudan, that center has sustained major damage, and now they're operating from Cairo. And so, yes, some of these are devastating, but I wanted to also point out that one of the limitations of the list is that we focused on pathogens that can cause invasive fungal diseases. That doesn't mean that some of the pathogens that were not included here are not important. Dermatophytosis, for example, dermatophytes, especially multi-drug resistant dermatophytosis, is something in our radar and is something that we are actually working to in the short term.
But even regular dermatophyte disease, onychomycosis, it's multiple billions of dollars are spent globally addressing this, and the treatments are awful. So even things that are not drug resistant but are incredibly common, and they wouldn't make this type of list because of the morbidity, although there is even morbidity with onychomycosis in terms of mental health and other potential superinfections with bacteria and things. It's amazing what fungi do.
Dimitrios, from your vantage point, how have you seen this priority pathogens list used in communications about fungal diseases, talks, papers, grants?
First of all, if you see discussion about investigational drugs, a lot of them are presented in the context of they address some priority pathogens in the WHO list, like say risafangin for Candidiasis, for Schwannosopics, for Mucor. So a lot of this discussion about drugs that are being investigated are in the context of do the work for the WHO fungal list. Second, having published a lot in this area, all the papers, mine and everything, had the same boring start. Fungal infections are important cause of morbidity and mortality in cancer patients. So now there is another modifier, you say, blah, 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 is very important for the WHO pathogen list. And all the presentations, typically slide 2 or 3 in a presentation, they throw the list before they talk about their fungus. So it's a standard slide everybody has and throw it in the presentation. Either going to talk about Aspergillus, Mucor, whatever. And having had the pleasure of just having gotten a PO1 for mucormycosis, we started our thing to say it's a bad disease and WHO has it in the important pathogen list. So it really has permeated to the academic endeavors in a major way and helped us.
I actually have a talk on the impact of the fungal priority pathogen list, which I've given in many places. I'm actually giving it at the Paraguayan Infectious Disease Society meeting later on this month. And it really is a great foil to talk about these things that are so critical in terms of policy, in terms of communicating science. And it's been just fabulous to have in hand. So, Dimitrios, what are you most concerned about with fungal diseases?
Yeah, I think we can talk hours about concerns and fungal disease in the future, but I will try to make 3 broad points. One is global warming and climate change is going to affect in a predictable and unpredictable way the geoclimatic aspect of fungal disease, something that actually we have published before the global warming about 20 years ago when we looked into Aspergillus cases in Seattle versus Houston, and we realized that Houston, our rays were flat, and in Seattle was connected to the precipitation by the rains. So I think we're going to learn a lot about climate change, and I think what people start realizing is much more complicated than we think. It's not only the thermal adaptation, but also all the coevolutionary framework. Fungi have a lot of plasticity in their genomes to adapt. For example, what do we know about precipitation, how it affects dark light cycles, soil changes, because microbiome, there have been some nice papers in Science how the microbiome of symbiotic fungi changes with thermal adaptations. What do we know about predators and their behavior in the soil, like amoebas? All of these things we don't know. So I think it's going to be a very fascinating scene in the following decades to know how that's going to change. Second is because I've seen that here in a cancer hospital, we're seeing now beyond the classic risk factors, prolonged neutropenia, corticosteroids, low-risk patients like lymphoma patients, chronic lymphocytic leukemia who get a design drug like a Bruton kinase inhibitor and they come with aspergillus in the brain. 2-3% of them, not a lot of them. Who are they? What is their immunity? I think it kind of challenges us to understand a little bit better fungal immunity and what governs it. And the third is, I think, is going to be a big push in the context of WHO and policy about lay persons education, policy education. How do we position fungal disease in the future? And this is something we're trying to do, not only us, ASHAM is trying to do that. My co-study group tried to educate a little bit the patient, bringing patient stories that are very powerful about what it is to have a chronic fungal disease. So I think a lot of geoclimatic changes, surprises about fungal immunity, new risk factors, new niches, and also a lot of push for education and policy.
So we shared earlier that you're the president of the MSG right now, and I don't think most people listening probably know what that is. Can you share a little bit about what the big points of that society is?
Yeah, this is an historical organization started in the 70s, funded by NIH, focusing on clinical mycology and clinical trials. Actually, most of the pivotal clinical trials in mycology have been done under the auspices of my co-study group. It was a society of US-based scholars on clinical mycology, trialists, new drugs, very active, Cryptococcus in HIV era, etc. Now the organization has changed a little bit, has become more global, more also focusing on education, patient advocacy. We have working groups about intellectually attacking other problems in modern mycology. For example, we have a working group for host transcriptomics to prognostication, how you do smart pragmatic studies, another working group, women in mycology, another working group, working on new diagnostics, how you mine data from EPIC or AI, trying to put some kind of intellectual context beyond the classic trialist endeavors that are still there. So it's a global organization of scholars, most of them academics, but obviously a lot of CDC interactions with colleagues from policy-making institutions, patient advocacy, and it's a very active in different ways. This gives me the pleasure to say we're going to have our biennial meeting next year in Colorado, September 19, and it's going to be a very rich program attacking different areas of modern mycology.
It's really terrific. And the things that they have done, as you said, the cryptococcal work was transformative in care. And they continue to do a lot of impactful studies that really change practice. Dimitrios, you've not only worked on best practice for use of antifungal drugs, but also on novel therapeutics. To me, one of the fascinating areas that you're working on is harnessing the host to combat fungal invaders. Can you share what you are doing and why this is a rational approach to dealing with mycoses?
I think I'm not to be credited for these areas entirely. I just witnessed the two revolutions working in a cancer hospital of modern oncology, which is basically cellular therapy and CAR T therapy and checkpoint inhibitors for oncology. Actually, One of the first papers is credited to Josh, who has been an inspiration with his nice paper in histoplasmosis published in EPNS. So what we thought was, wouldn't it be nice to get things that are already approved by FDA? And we were focusing on non-cellular therapeutics, typically checkpoint inhibitors that was the thing to study in a cancer hospital with or without traditional immunotherapies like GM-CSF gamma interferon, and see if those somehow augment immunity in the setting of immunosuppression. Initially, we came with this hypothesis when checkpoint inhibitors were very hot in leukemia. Now they're not very hot of an intervention. And we put this double hit hypothesis. We give checkpoint inhibitors to leukemia gets better. And if they get aspergillosis, also aspergillosis gets better because they're a checkpoint inhibitor. So we have done animal models when we treated immunosuppressed animals with a fraction of the dose used in oncology in a attenuated schedule without any antifungals. And we found we have proven protection and survival benefit by just giving GM-CSF in the past and now checkpoint inhibitors. When we combine checkpoint inhibitors with drugs that alter the immune system for the better, immunomodulatory drugs like echinocandins, we saw synergy. So one of the things we are still very hot on, we have a mouse model of leukemia. When we raise the bar and try to say how much this intervention work in the leukemia microenvironment, we're having this very active product and we're pursuing. We're much more hot with the non-cellular therapeutics. We've done work with CAR T cells, with Dectin-1 recognition to attack Aspergillus. We just realized it's a little bit more cumbersome. It's not real life. It takes 20 days to develop basically product. It's a lot of donor variability. This technology is exploding in oncology. We study second generation CAR T cells and now they're studying fifth generation CAR T cells. And we were not impressed by the outcomes being better than non-cellular therapeutics. So we've done some work also with CAR T specific for fungi. But this work is a little bit on the back burner now. And we're more focusing on non-cellular therapeutics. We're going to use them for Mucor. It's a part of this PO1 we're going to have with or without GM-CSF. The other thing we are doing, and we just published just a couple of months ago, I'm a clinician by nature, so a lot of ideas come being in the floor. So the new phase of opportunistic mold infections in leukemia is not neutropenia anymore. The typical patient is somebody with refractory leukemia for 2-3 years who walks around, who has 30,000 WBCs with 80% blasts. And numerically, his neutrophils are adequate, over 1,000. So we studied the impact of blastemia to effector immune cell responses, and we found if you're blastemic, you are as bad as being neutropenic. And if you're blastemic, and neutropenic is the horrible group to be. So we've done some transwell assays when we exposed blasts and effector immune cells, and this interaction is bad. The effector immune cells cannot kill the fungus. So a part, a twist of our cellular therapeutic program is to work in the environment of blasts to see how much cellular therapeutics alter immune responses. So I think we need to sense what's going on in your microenvironment of oncology and just make observations and go and study. Those are the exciting things we're trying to do in this space.
Since we keep changing our patients and we also keep having things emerging from the environment, it sounds like some of us are still going to have a job in a few years.
Yes, definitely. It's going to be more challenging. It's going to be more niche, more intellectually nuanced how to do that. The easy things have been described: prolonged neutropenia, steroids. But how you study a patient who comes with aspergillus in the brain if he got ibrutinib, for lymphoma? And one of the things we are putting as an idea, and I have a junior faculty join us soon, is to study the idea of tandem immunosuppression, like people who have a Lyme disease, autoantibodies or whatever, and then they get like chemo and then they have a full-blown infection. So there are going to be a lot of ideas, or the other thing is what is the impact of comorbidities to risk, something we don't think about. What does it mean to have diabetes, liver disease, and get chemo, So there are going to be a lot of sophisticated little questions, but I think the easy questions have been already out the door. Now it's the time to see how to personalize risk of acquisition and outcome.
Wow, quite a ride. So, Dimitrios and Hatim, question for both of you. Where do you think medical mycology will be in 10 years from now?
To me, the FPPL was a start, but we are nowhere where we should be. I think those kind of ideas, this type of science that Dimitrios was discussing just now, needs to be funded, needs to be supported. I really am worried about the implications of the global cuts on medical funding, public health funding across the board, but especially in these areas. I think the assumptions oftentimes, mostly due to a general lack of understanding how these scientific endeavors work, that this work is not important. Why do we need to fund this? I did answer this question ironically when we released the Fungal Priority Pathogens List. A journalist asked me, why is this important now? And in my response, I said, we cannot wait until we have a catastrophe unfolding before our eyes like COVID-19 to then put all the funding, all hands on deck. Rather, we need to invest early on, not only in the basic research to understand the implications and the dynamics and the impact of climate change and the impact of all these drivers, but also in research that is truly innovative and not just the traditional research that could help us come up with truly innovative and impactful solutions for some of these complex problems. I hope that we continue to move ahead, but I have to say at this point in time, I am a little bit concerned with the global situation.
For me, it's a timely question because I'm going to be giving a talk in ID Week and I'm asked to prognosticate about the future. And I kind of try to organize a little bit my thinking about, I've been doing clinical mycology 27 years. I think, as we said before, we're going to see new fungi emerging and expansion of geographical range of common fungi is happening, obviously. And with the help of WHO and other policymakers, fungal epidemiology will become global and not what US does or Brazil does or whatever, like a global effort to mitigate resistance and have better access to care, better diagnostics. I hear the concerns about the climate, the political climate, but I remain optimist that's going to change long term to the better. For clinical, because I work in a cancer hospital where there is a lot of excess of things, and sometimes we do too many things for people who are on the end of the road for their underlying disease. I think there's going to be more emphasis about smart care, who gets what, when, and how. We're going to look a little bit more into attributable versus contributable versus global mortality. In other words, a patient who dies with end-stage leukemia and aspergillus, what can be done for him compared to an early onset of disease before you go to transplant? How often do we do CTs? How do we do therapeutics, combination, new drugs, immunotherapeutics? I think we're going to see a lot of emphasis to preemptive therapy like we do for CMV, like a new blood marker and then early before we wait a culture to grow when it's going to be too late. So those are going to be interesting things. And also everything becomes outpatient now. We're doing even CAR-T therapy outpatient. A lot of emphasis to non-hospital care, home care, outpatient care. There's going to be a lot of mental shift, how we do things in mycology outside the hospital. Then for research, I think a lot of things we already talk about. I think immunogenetic risk for risk of fungal disease and prognosis, how you incorporate this risk to time-honored clinical scorecards of risk, like being old, having comorbidities, having immunosuppression. Talk a little bit more, I think, something we haven't talked about too much is beyond MICs, beyond resistance. If you look in the exciting data, we just put an editorial with David Perling about heteroresistance and tolerance, something we don't look in the lab. What do we know about this in the context of how drugs work, especially for echinocandins and problematic fungi like Candida auris? I think we're going to look, because with the NIH having all this mandate about mouse models, scrutinize, are they really needed? Maybe it's going to be an explosion to organoids and also non-mouse model I think there's going to be also an explosion of nanotechnology for smart delivery of drugs through the skin, inhalation, vaccines, and also a lot of effort to public policy, patient-reported outcomes, what is important at the end of the day. So it's going to be a lot of excitement. Those questions are more complicated than they sound. And some of them are interrelated questions, but I think it's going to be a very interesting scene to see. I think overall in 20 years, it's going to be very close to personalized medicine in fungi and better outcomes.
Very exciting to hear. I do want to acknowledge that we have not talked about certain areas of fungi, which means that we have future podcasts that we can do in terms of antifungal stewardship and diagnostics. But we have had an illuminating discussion and showed that there are promising roads ahead. And I want to give you both the opportunity to share any last messages for our listeners. Hatim?
Sure. A lot of these infections and the burden remains unseen. I really think that this is the tip of the iceberg. I hope that in the coming years, we're able to have a clear idea about the extent of the burden of some of these infections across the board in limited income settings too. I hope also that the Fungal Priority Pathogens List is just a start and that we will continue to build on it. Dimitrios spoke about personalized care, and I want to talk about also focusing on some of the populations that are now continuing to face displacement, migration, water scarcity, and the impact of climate change and how that will play into the future. But for now, I think all we could hope for is to continue this work. Maybe in the future, we will be able truly to look back and say that we did all we could in this moment to address these challenges.
From my standpoint, I remain optimist. I think in the future is going to be an acceleration of success we had. As I'm getting older a little bit, I know I look like 25, but I'm 62. I kind of reflect what success has been in fungal disease in these 27 years I've been a faculty here. So when I first came to MD Anderson as a postdoc in 1990, fluconazole has been an investigation drug. Candid albicans was the dominant bug in leukemia, something we never see anymore. If you get aspergillosis, you got amphobideoxycholate. In 4 weeks, 6 weeks, you had renal failure. In 2 months, you were dead. No one was given any chemo back then. Transplant, forget about it. And listen where we are now. Having aspergillosis is not a problem. You go transplant, no problem. People live with aspergillosis for years. Actually, we had some data we haven't published yet, but we'll present it next month. When global mortality, if you get a mold infection, has remained stable, maybe reflecting some improvement in supportive care and leukemia care or transplant care, but attributed mortality, with all the difficulties how to assess attributed mortality, has dropped. In other words, success here is these people live for a long time, months or years, and they keep getting the hope of getting another miracle around the corner to control their disease, go to remission, and be cured. So how success is not how success is defined for bacterial infection or tuberculosis or whatever. Success here has been living longer with your cancer and fungal disease and keep fighting until you get to a solution to your underlying disease. And I think mycology, we have 12 drugs, we have better diagnostics, better understanding of pathophysiology, not perfect, better understanding. So we have done a lot of improvements over the last 30 years, but also we have defined what are the questions to be answered. And I think in 10, 20 years, we're going to be even better with more personalized approach, especially if the global climate of funding and policy is conducive to this.
Thank you so much, Dimitrios. Thank you so much, Hatim. Hatim Sati at WHO here in Geneva, Dimitrios Kontoyiannis at MD Anderson in Houston, Texas, many years ago, saved by Poseidon. And thank you for listening to Communicable, the CMI Comms podcast. This episode was hosted by Josh Nosanchuk in New York, USA, and myself, Angela Huttner, in Geneva, Switzerland, editors at CMI Comms, ESCMID's Open Access Journal. It was edited and produced by Dr. Katie Hostetler-Oy and peer-reviewed by Dr. Andrisa Jaja from Elbasan, Albania. Theme music was composed and conducted by Joseph McDade. This episode will be citable with a written summary referenced by a DOI in the next 8 weeks, and any literature we've discussed today can be found in the show notes. You can subscribe to Communicable wherever you get your podcasts, or you can find it on ESCMID's website for the CMI Comms Journal. Thanks for listening and helping CMI Comms and ESCMID move the conversation in ID and clinical microbiology further along.